The COVID-19 pandemic has brought into sharp focus many of the troubling features we already knew about health disparities but have failed to address. During the 2009 flu pandemic, the death rate was 3 times higher in the poorest fifth of England's population than in the richest. COVID-19 is showing no signs of departing from that pattern. And because of the way the socioeconomic dice fall, this also has a racial dimension. Recent data from the UK's Office of National Statistics show that Black, Asian and minority ethnic populations are disproportionately affected by COVID-19. It has hit some of the poorest ethnic minority populations hardest, those in low-paid or unstable employment, who live in crowded accommodation and adverse neighbourhoods, have underlying health conditions, and for whom healthcare is less affordable or less accessible. For urban designers and environmental health researchers like me, this pandemic has sparked a debate about how our cities should be built, and perhaps more importantly, how they can better respond to current and future crises. Drawing from history, I reflect on key pathways through which urban design and planning must focus on evidence-based, health-promoting interventions in an equitable manner. If the past is any indication, disease outbreaks shape our cities. Some of the most iconic developments in urban planning, such as London's Metropolitan Board of Works and mid-19th century sanitation systems, were developed in response to public health crises such as cholera outbreaks. At the turn of the 20th century, public parks became popular in the United States as tuberculosis swept through the country. Now, COVID-19 is joining a long list of infectious diseases like the Spanish flu of 1918 and the Ebola virus disease of 2014, and it is likely to leave lasting impacts on urban spaces. The spread of COVID-19 in some of the world's dense, populous cities has raised questions about urban density. Crowding on sidewalks, in buildings and public spaces is thought to make physical distancing difficult or impossible and increase the risk of contagion. This critique against density goes back to the late 19th century when some American civic leaders embraced the notion that social problems such as disease and poverty stemmed from crowded and unsanitary conditions in cities. However, this idea may not be so clear-cut with regard to the spread of COVID-19. Emerging findings from my research show weak associations between high density and COVID-19 cases and death rates. Numerous hyperdense metropolitan areas, such as Singapore, Hong Kong, Tokyo, and Seoul, have succeeded in containing the spread of COVID-19 compared to low-density cities. Dense Asian cities in particular responded swiftly with public health measures such as testing, contact tracing, isolation, and quarantine. It appears that these classic public health measures can overcome contagion risk due to higher density. Density is likely just one of several key factors that determine how vulnerable places are to COVID-19, and it plays a smaller role compared to socioeconomic factors. The starkest indication of this is the issue of space, both private living space and the wider neighborhood public space. Being locked down for days on end may be easier if you have plenty of space indoors and access to outdoor spaces like parks, but for people whose living conditions are cramped, it is a much less appealing prospect. The UK's Office of National Statistics has reported that the percentage of homes without a garden is higher among ethnic minorities. There is a compelling link between outdoor exercise and a strong immune system, as suggested by the success of outdoor hospitals during the 1918 influenza pandemic. This search for fresh air and green space is glaring in the poorest neighborhoods of our cities, and it is likely to have negative implications for physical activity, mental health, and the severity of COVID-19 infections. With physical distancing likely to be the norm over the near future, we need to analyze how the design of our buildings, neighborhoods, and cities impacts health, social mobility, and disease control, among other factors, and how in the coming months, dense cities globally may need to adapt quickly. Cities across the world are already implementing temporary measures to make streets safer for walking and cycling, such as reallocating road space away from motor vehicles and lowering speed limits. Cities must embrace the opportunity and ensure that the positive developments in urban planning become permanent fixtures of our spaces. Tackling socioeconomic inequities is a core value for public health, but has not always been a part of emergency preparedness plans. It is now more crucial than ever to develop policies to create healthier communities equitably to strengthen our preparedness for future pandemics.